Great.
All right, thank you.
No problem. So my name is Neil. I'm one of the chief residents at Rutgers out of New Jersey. And Mike and Ryan have been, gracious enough to set all this up, and I hope to give you guys a very brief overview on cerebral vasculature. We're all used to seeing the circle of Willis just like this. This is how I studied in medical school, and you sort of see it as this flat, non-3D picture all the time. And you try to make sense of this, and you look at CTAs, you look at angiograms, and usually it doesn't make sense. A lot of the times you're looking at it and you can't, when you're looking at a CTA or an angiogram, you're like, this is not what it looks like in the textbook. So we have all studied this extensively for step one, medical school, whatever it is. And we always see this picture. And this is a great picture to memorize the names of the arteries. But in general, it's not a great picture to think about it in real life. So everybody knows about the ICA and the MCA and the ACA and the PCOM and how the PCOM connects to the posterior circulation. But in reality, when you're looking at a CTA or an angiogram, it does not look like this. So I'm going to try to help you guys understand conceptually what it looks like in 3D and go through all the branches and all the major vessels. So we have the ICA that we always talk about, and this is a lateral angiogram from diagnostic cerebral angiography, which is by Dr. Osborne, and it's a great textbook to learn about how vessels are, the anatomy of vessels and the embryology and all of that. So we'll hopefully by the end of this talk, you guys will be able to name all these branches. So we can go through the ICA first, and the easiest way to think about it is, separate the ICA into segments. So there's a C1 segment, the cervical segment, that does not have any branches, that runs through the neck. C2 is the petrous segment that has two branches. That's the petrous segment is an L-shaped segment. And the one thing to remember a lot for when you guys become neurosurgery residents, neurology residents, that this is the segment that's most vulnerable to dissection, because it's fixed within bone and it comes from the cervical segment, which is free in the neck. The petrous segment is a short vertical segment that turns anteromedially and then goes in front of the cochlea. It has two branches, the Vidian artery and the caroticotympanic artery. These are just important branches to remember because eventually, they may be involved in some pathology. And then the C3 segment is the lacerum segment that lies above the foramen lacerum, and it goes to the petrous apex to the cavernous sinus. And then there's a C4 segment, which is a cavernous segment, and that has two trunks, the meningohypophyseal trunk and the inferolateral trunk. And the things I've written down here are just in general, just good to know, but they're a little more advanced. So you just have to remember that the C4 cavernous segment has two trunks, the meningohypophyseal and the inferolateral trunk. So this is just a nice little illustration I found online about the segments of the C4 the cavernous segment. So if you look at this is an axial view. If you see in the middle here is the pituitary gland. And so you see that the cavernous ICA segment comes up, becomes a supraclinoid ICA segment. And there's all these small branches that come out. And here is a nice depiction of the meningohypophyseal trunk and the inferior hypophyseal artery. And they become important when you have dural AV fistulas. And it's a nice question that people will ask you, where do you think this tentorial dural AV fistula arises from? And generally it's from the tentorial artery. But again, like I said, a little more advanced. Then there's a C5, the clinoid segment that does not have any branches. And you see here, it's a short intradural segment between the proximal and distal dural rings of the cavernous sinus. So, we'll see the proximal ring here and the distal dural ring here. And there's not really any major branches that arise from this short segment. Then there's the ophthalmic segment. There has two branches. So the big thing to remember about the ophthalmic segment of the cavernous ICA is that it is the first truly intradural segment of the carotid artery, and it goes from the distal dural ring to just below the origin of the PCOM. And it has two major branches: the ophthalmic artery, which supplies the retina. The ophthalmic artery arises from the anterior-superior aspect of the vessel and passes through the optic canal with the optic nerve. The ophthalmic artery has extensive anastomosis with the external carotid artery branches. So a lot of the times, if you have patients that have an ICA occlusion, you'll see that the ophthalmic artery actually has reverse flow, or flow from the external to the internal, actually through the distal branches. So, we've all learned about carotid artery stenosis or carotid artery occlusions, and you wonder how a lot of these people over time can still supply their brain. The vasculature is able to adapt to the occlusion over time. Obviously, if it's an acute occlusion, which you guys will learn about later today during the stroke talks, it's very different. But if you have something that's a chronic occlusion, a lot of the times the ophthalmic artery is able to sort of reverse flow and give blood supply to the brain via the ECA. The other branch that's important from the ophthalmic segment is the superior hypophyseal artery. And this arises from the posterior aspect of the ophthalmic ICA. And this supplies the anterior pituitary and the infundibular stalk, as well as the optic chiasm. And usually the ophthalmic artery, you can see on angiography, the superior hypophyseal artery, very small artery that usually you can't really appreciate on angiography or CTA. The last segment of the ICA, and probably the most important to understand, is the communicating segment, which has 4 branches. So the first branch that comes off after the ophthalmic and the superior hypophyseal is the posterior communicating artery, or the PCOM. And this has many perforating branches. The largest is the premammillary, or the anterior thalamo-perforating artery. And the posterior communicating artery is the artery that communicates between the anterior circulation and the posterior circulation. So that's why, of course, it's called the PCOM, or the posterior communicating artery. And it has several perforating branches that supply the thalamus and other important structures deep in the middle of the brain. And these are very important to provide consciousness. And obviously a PCOM stroke can be devastating in people who have large perforators from this artery. The next segment after the posterior communicating artery is the anterior choroidal artery, and it arises about 1 or 2 millimeters right after the PCOM takeoff. Initially, it courses posterior medially, and then it turns laterally in the suprasellar cistern and enters a choroidal fissure of the temporal horn. The main thing to remember about this artery is that despite it being very small, it has devastating effects if this artery is taken. Because of its supply to the medial temporal lobe, the basal ganglia, and the infralenticular limb of the corpus callosum, it can cause hemiparesis, hemianesthesia, and homonymous hemianopsia. And that actually I highlighted in blue because this is generally a board question for neurosurgery residents. And it's also important to remember how this small vessel, if it's ever taken during aneurysm clippings or any other type of intracranial surgery, can cause devastating effects. Then you have the ACA, or the anterior cerebral artery, and this runs in the interhemispheric fissure and has 3 defined segments. So the ACA supplies the anterior 2/3 of the medial hemisphere and the corpus callosum, and the inframedial surface of the frontal lobe. So the main thing to remember about the ACA is that it supplies the territory. If you look at a CAT scan, an axial view, it supplies the frontal lobe and runs in the midline, basically. So if you think about how the homunculus looks or how the motor cortex is separated, an ACA stroke can cause leg weakness mainly. That's what you have to remember. So there's obviously, like I said, there's three defined segments. You have the A1 segment, which is a horizontal segment. This extends medially over the optic chiasm and goes towards the midline. And the ACOM is what joins the left and the right A1 segments and the A2 segments. So you have a left ACA, the right ACA, they come up and they form an H, and the sort of the artery that runs across the middle to join the two lines of the H is the ACOM. Now, obviously, people's anatomy varies, and sometimes people have just one ACA or a hypoplastic ACA on the contralateral side. So they have a large ACA on one side and a small ACA on the other side, and we call that a hypoplastic A1. And these things are important to know when you're doing aneurysm surgery, because they sort of can dictate which side you're going to approach the aneurysm, if there's an aneurysm at the ACOM, and so on and so forth. So the A1 segment has a couple of branches. There's the medial lenticular striate branches, and these pass superiorly through the anterior perforated substance, and they supply the medial basal ganglia. And the other big branch that you have to remember from the A1, most of the time it comes off from the distal A1, but it can come off the A2 branch as well, is a recurrent artery of Hubner. And this, like I said, arises from the distal AC or the proximal A2, and it curves back above the horizontal A1 to supply the inferior medial basal ganglia. It supplies the caudate, parts of the putamen, and the anterior limb of the internal capsule. An injury to this vessel causes hemiparesis and sensory loss on the contralateral side. So the recurrent artery of Hubner is very important when you're discussing aneurysm surgery. And if you're clipping an anterior communicating artery aneurysm, the A1 is something you have to identify, during your dissection. The recurrent artery of Hubner is something you have to identify during your dissection, because that's one major vessel that you cannot take, or you cannot ignore during your surgery, because you have to make sure that that's filling, because obviously if that artery is taken or if that artery is injured, it can cause some devastating complications of the surgery, which is hemiparesis and sensory loss on the contralateral side. And that's also a question that's frequently encountered on the neurosurgery boards. The other segments of the ACA are the A2, the vertical segment. This courses superiorly in the interhemispheric fissure. It goes from the ACOM A1 junction to the corpus callosum, to the rostrum of the corpus callosum. And the A2 segment has two major branches that you have to remember. It's the orbitofrontal and the frontopolar, and these supply the undersurface and the inframedial aspect of the frontal lobe. Now, once the vertical segment of the A1 of the ACA is done, then you get into the callosal segment. And this curves around the genu of the corpus callosum. So if you're looking at a sagittal image of the brain and you think about where the corpus callosum is, the A3 segments are right at the rostrum of the corpus callosum, or the beak of the corpus callosum. And there's two major branches here, the pericallosal and the callosum marginal. The pericallosal is the larger branch, and it generally runs between the dorsal surface of the corpus callosum and the cingulate gyrus. So I just remember, if you're memorizing which branch is which, just remember PC. It's pericallosal and then callosum marginal. So pericallosal is the first one that runs right on the surface of the corpus callosum. And then you have the callosum marginal, which courses over the cingulate gyrus in the cingulate sulcus. So it's the one that's higher up if you're looking at a sagittal view. Now we go to the middle cerebral artery, and this supplies the lateral surface. We said that the ACA supplies the medial surface of the cerebral hemisphere. The MCA supplies the lateral surface of the cerebral hemisphere. There's a thin strip at the vertex, like I said, that's supplied by the ACA. And then you have the occipital and posterior infraparietal lobes, which are supplied by the PCA. So the middle cerebral artery, the big trunk, is called the M1. It extends laterally from the ICA bifurcation into the sylvian fissure, and it either bifurcates or trifurcates. So we always talk about M1 into M2. So this distinguishing between the M1 and the M2, there's at that junction, there's either two vessels that come off the M1 or three. or more in certain people, but usually it's 2 or 3. And the big branches of the M1 that you have to remember are the lateral lenticular striates, and these supply the putamen, the caudate, and the external capsule. Now we saw the medial lenticular striate arteries, they come off the A1. The lateral lenticular striates come off the M1. In general, these arteries are so small that you can't normally appreciate each individual artery, but you can see their vascular supply on an angiogram, a diagnostic angiogram. The one other major branch from the M1 is the anterior temporal artery, and this supplies the tip of the temporal lobe. So it's usually the first branch that you can see on angiogram from the M1 MCA. And then there's a polar temporal artery. This is supplying the polar and the anterior lateral portion of the temporal lobe. And this artery, you can't always see on angiography, but it can also branch off the anterior temporal artery. You have the M2 insular segments, and these arise from the post-bifurcation trunk. So once the MCA bifurcates into the M2, you see the insular segments. The opercular segments are the branches that loop at or near the top of the sylvian fissure, and then they course laterally under the parts of the opercula or the overhang of the frontal lobe. So these would be the M3 or the opercular branches. Like I was saying earlier, this is the M1, and then you see off the ACA, you see the medial lenticular striates, and off the MCA, you see the lateral lenticular striates. And then you get into the M2, the M3, and then the M4 are the cortical branches of the MCA, and they exit the sylvian fissure over the lateral surface of the hemisphere. The next segment of the ICA, which we talk about, or actually the vertebral artery, is the posterior cerebral artery. And we always talk about the PCOM communicating between the anterior and the posterior circulation. So the PCOM communicates between the ICA and the vertebral basilar circulation, or the posterior circulation. And the other branch the last branch, obviously, of the vertebral basilar circulation that we talk about is the posterior cerebral artery. And I included it within this circulation because this is all supratentorial or above the tentorium. So you have the P1 posterior cerebral artery, the pre-communicating artery that extends laterally from the basilar artery bifurcation to the PCOM junction. So you have the vertebral artery that bifurcates at its apex, and it gives off the two P1 branches, or the two P1 posterior cerebral artery branches. And its P1 is the segment of the posterior cerebral artery right before the PCOM joins from the anterior circulation. And this P1 segment lies above the oculomotor nerve, or cranial nerve 3, which you can see right here. So this is the vertebral artery becoming the basilar artery. And this artery we'll talk about later. It's a superior cerebellar artery, but the posterior cerebral artery is right here, and you can see it go back. This is a sagittal view of the brain. And you can see it go back, and it lies right above the third nerve. It has some important branches, the posterior thalamoperforating arteries, which supply the thalami bilaterally and the walls of the third ventricle. And then we go on to the next segments, which are the P2 segments, which is the ambient segment. This extends from the PCOM P1 junction. It runs in the ambient or perimesencephalic cistern, and it goes posterolaterally around the midbrain. So that's the part of the posterior cerebral artery that wraps around the midbrain here. And this lies right above the tentorium and the cisternal segment of the fourth nerve. And the P2 segment has many important branches, the anterior and posterior temporal arteries, the thalamogeniculate arteries, the peduncular perforating arteries, and then two big branches that sometimes will become important in AVM surgery of the medial posterior choroidal artery and the lateral posterior choroidal artery. And these are important to know. Obviously, you should know the anatomy in general, but these can become larger if you have different types of AVMs. These vessels can supply them, and it's important to know these branches and know what they supply and what happens if you take them, and exactly what they are and where their locations are. So the medial posterior carotid artery curves around the brainstem and courses supermedially, and it enters the tila choroidea and the roof of the third ventricle. And then the lateral posterior carotid artery enters the lateral ventricle, and then it travels with the choroid plexus and it curves around the thalamus. So again, these are all images from this book by Dr. Osborne, great textbook in general to have if you're learning about cerebral anatomy and pathology as a first-year resident, or even now for me as a chief resident. It's nice to go back and see some of these pictures. The next segment of the posterior cerebral artery is the quadrigeminal segment, or the P3, and this lies entirely within the quadrigeminal cistern, and it begins behind the midbrain and enters where the PCA enters the calcarine fissure of the occipital lobe. So you can see the P3 segment is here, quadrigeminal cistern, and then you have the P4 segment, or the calcarine segment, which terminates within the calcarine fissure and divides into the terminal PCA trunks. So here, where if you guys can see my mouse, that's where it is. And then there's a medial trunk and the lateral trunk of that P4 segment that supply the occipital lobe. So there's many variants of the posterior cerebral artery that you'll learn about as you go forward. But the biggest ones to know are the fetal PCA. Some of you may have heard about the fetal PCA. And the fetal PCA is just the fact that the proximal PCA arises from the ICA via the posterior communicating artery instead of the basilar bifurcation. So I showed you guys something that looked like this image here on the bottom, where you have the basilar artery bifurcating into the two P1 segments. So let me go back here and I'll show you that image here. You can see one PCA segment here. The P1 segment, instead of arising from the top of the basilar artery, arises from the posterior communicating artery. So this is an angiogram, a lateral angiogram of the ICA circulation. So you see the ICA here coming up, and we talked about the first branch of the intradural ICA being up the ophthalmic artery, which this is the back of the head, this is the front of the head, this is the top, this is the bottom. So this is where your eyes would be up here. So this is the ophthalmic artery going to the eye. But if you look here, there's a very large posterior communicating artery. And usually the PCOM runs from here to here, just about there. And so the fetal PCA is a variant where the fetal circulation is preserved and the posterior communicating artery supplies the posterior cerebral artery circulation, meaning that the PCA comes off the posterior communicating artery instead of the vertebral artery. And it's an important variant to appreciate and recognize, especially during aneurysm treatment. You'll learn about that as you go forward. This is seen in about 10 to 30% of cases. And then the other variant of the posterior cerebral artery is called the artery of Percheron. And that just shows you that there is a single dominant thalamoperforator artery, which arises from the P1 segment and supplies the rostral midbrain and the bilateral medial thalami. So if you look here, this is your basilar artery. You have a lot of perforators in the middle of the basilar artery that supply the pons, or the pontine perforators. You have this superior cerebellar artery, and you have the posterior cerebral artery here at the top. So the artery of Percheron is a variant that can be devastating. So if you think about a basilar artery stroke, or a stroke that affects the top of the basilar artery, if you have this variant, which is the artery of Percheron, and that gets occluded, then you've knocked out bilateral thalami. So that's devastating, because we all know that you have the reticular activating system, and if you knock out the bilateral thalami, the patient is going to be in a coma. So that's an important variant to recognize, and it's also a very important boards question for neurosurgery residents. Then we go to the vertebral basilar system, or the posterior circulation, as everybody calls it, and you have the vertebral artery runs through the cervical spine. So it starts from the subclavian artery, goes posteriorly and enters the transverse foramen at the 6th cervical vertebra, or C6. And it runs within the transverse foramina of the C6 to C3. So you can see it running up here and running up here bilaterally. And at C2, it sort of comes outwards and continues superiorly. So you see the foraminal segment, which I talked about, which is C3 to C6. And then it makes this inverted L, and it turns upward to pass through the C1 transverse foramen, which is right here. The biggest branch from here is the anterior meningeal artery, and that just supplies the dura. So the V3 segment, or the extraspinal segment, begins after the vertebral artery exits the C1 foramen, and it stays on top of the C1 ring right here, which we call the J groove. And the V3 segment curves posterior-medially, so it goes back and medially, as you see here, around the atlanto-occipital joint, which you see here. And it makes a sharp anterior superior turn to pierce the dura at the foramen magnum, right here. And the big branch from the V3 segment is the posterior meningeal artery. So the V4 segment, or the intradural segment, is here, depicted by this arrow is actually pointing to another branch, but this is the V4 segment. And off the V4 intradural segment, you have the anterior and the posterior spinal arteries, the medullary perforating branches, and the segment that you see here is the pica, depicted by this artery. The pica curves around the tonsil of the cerebellum, and it gives off the perforating medullary, choroid, tonsillar, and inferior cerebellar branches. So a pica stroke, you probably already learned in medical school, or if some of you are going to medical school, you learn this, causes Wallenberg syndrome. So ipsilateral loss of pain and temperature in the face, contralateral loss of pain and temperature in the body, just because of the way the pain and temperature tracks are. The ipsilateral larynx pharynx paralysis, ipsilateral Horner syndrome, vertigo, ataxia, and nausea, because of the way the pica supplies the medulla and the nuclei in the medulla. These are the symptoms that you get. So you just have the main things you have to remember about a pica stroke. The buzzwords are ipsilateral loss of pain and temperature on the face, and then contralateral loss of pain and temperature in the body. So those are generally the ones that are the topics that are tested with a pica stroke. The basilar artery. So the vertebral arteries unite at or near the pontomedullary junction. So the two verts become the basilar. And the basilar artery courses superiorly in the prepontine cistern, and it terminates in the interpeduncular fossa by dividing in the PCAs, as we talked about earlier. So the first major branch off the basilar, once the two verts unite, is the ICA. And the ICA courses ventromedially to cranial nerves 7 and 8, and it loops in the IAC. So this is a nice axial image showing the ICA and the different branches off the ICA around cranial nerve 7 and 8. So these are your lower cranial nerves here, 9, 10, 11 coming up. And then these are the branches of the ICA that you see here. So the ICA supplies both nerves as well as the thin strip of the cerebellar hemisphere right behind the petrous temporal bone. And some of the big branch that you have to know off the ICA is the labyrinthine artery, or the internal auditory artery. And this artery accompanies cranial nerve 8, or the vestibular nerve, into the internal auditory canal. And this artery supplies the vestibular apparatus and the cochlea. So the board question will be, what artery is this? That, the patient had hearing loss afterwards, and that's the labyrinthine artery. The SCA is the next major branch of the basilar artery right before the PCA, and this courses laterally right below the third nerve. We talked about the PCA running above the third nerve. The SCA runs right below the third nerve, and it goes posterior laterally around the midbrain just below the tentorium. So, we talked a lot about the anterior circulation and then the posterior circulation, obviously, but I talked about the branches before. So I will ask you guys again, if you can use the chat I'm trying to figure out, let me see how I can use a chat function here, but so the C1 branch, how many, it's the C1 segment of the ICA, how many branches does it have? If anybody can write in the chat. Can't seem to pull up the chat. But anyway, we talked about the C1 being the cervical, C2 petrous, C3 lacerum, C4 cavernous, and we talked about the cavernous segment of the ICA having two major trunks, the C5 running between the proximal and the distal dural rings. Then you have the ophthalmic segment, and then you have the communicating segment. So here is a nice depiction where you can see the PCOM coming off, the anterior choroidal coming off, and then this is the ICA terminus here, where you see the anterior cerebral artery and the middle cerebral artery here. And here you see the MCA has a bifurcation. It's another nice image online showing the extensive anastomoses. This is a very complicated picture, but if you just break it down, you can see the ICA here coursing this way. And it labels all the segments. But you see the C4, the petrous segment coming up, and we talked about the cavernous segment having, the C4 being the cavernous segment. You see it having the major branches of meningohypophyseal trunk or the inferolateral trunk, and then becoming the clinoidal segment. And then you see the ophthalmic artery coursing here, going through the optic canal with the optic nerve, C6 and C7, and the posterior communicating artery here. And this is a nice picture just showing how, we always, like I showed you guys the picture before of the circle of Willis and it being a flat diagram showing all the vessels, which, like I said, is important to recognize the names of all the arteries from that image. But that's not how the vasculature looks. And one thing that I appreciated as I became a resident, I learned more about the anatomy, is that there are extensive anastomoses between various circulations. So the external carotid artery, the ECA, has many branches has a bunch of branches, obviously, in the face and the scalp and all of that. And these branches have a lot of anastomoses, which you guys will all learn about, and it's beyond the scope of this lecture with the ICA. So as I mentioned earlier, when you have a internal carotid artery occlusion that occurs over time, many of these anastomoses can become more prominent or can reverse their flow depending on the pathology. So these are some ECA branches that you can see are communicating with ICA branches. Then I wanted to see if this would have been a little, you guys could unmute, then we would have gone through all the names of all these vessels. But if you look at this image, this is an anterior or an AP view of the vertebral artery and the basilar artery. This is a lateral view of the vertebral and basilar arteries. And number one here is the basilar artery. Number two is number two is an ICA, the left ICA. Number three is the loop of the pica coming off. It's an ICA pica sort of variant here. Number four is the right ICA. Number five is the left. Number six is the hemispheric branches of the pica. Number seven is the superior cerebellar artery here. Number eight are the superior vermian branches of the SCA. And number nine are the hemispheric SCA branches. So all in all, for you guys to remember, this is a vert. This is a vert. The two verts combine to form the basilar. The ICAs come off the basilar first. Then you have the SCA bilaterally here, left and right. And then you have the PCAs. And then the major branches off the vert are the picas. And like I said, the first major branch off the basilar is the ICA. This is on the lateral view, the basilar artery is here. This is one vert, this is the other vert. And after they combine, they give off the ICA. Before they combine, they give off the pica. And the last two branches are the SCA and the PCA. So there are many, like I said, there are many anastomoses between the anterior circulation, the posterior circulation, and the external carotid circulation. But there are also many embryonic carotid basilar anastomoses. So as the fetus is developing, there are many anastomoses that regress over time between the anterior and posterior circulation. So there's four major ones, and each is named according to its anatomic relationship with specific cranial or spinal nerves. So there's the persistent trigeminal artery, the persistent otic artery, the persistent hypoglossal artery, and the pro-atlantal intersegmental artery. And this is probably a little bit above the scope of medical students, but they're still important to know. So the biggest one and the most common one is the persistent trigeminal artery, and this is an anastomosis between the cavernous ICA and the basilar artery. So there's different types. Again, don't remember those for now. Of this type of variant, the posterior persistent trigeminal artery supplies the distal basilar. The PCOMs are usually absent, and the proximal basilar is hypoplastic. That's Saltzman type 1. And then the persistent trigeminal artery can fill the superior cerebellar arteries, while the PCAs are supplied via the patent PCOMs. So these are two different types of variants. And so 60% of these can course posterior immediately through the sella. So it's important to know if the patient has a persistent trigeminal artery when you're doing transsphenoidals, because 2/3 of the time almost these can go through the sella, and you can encounter them if you're taking out a pituitary tumor through the nose. It's referred to as Neptune's trident because it looks like a trident, and you have a large persistent trigeminal artery. And a quarter of these variants have associated vascular abnormalities such as aneurysm, moyamoya disease, aortic coarctation, and arterial fenestration. So just remember, if you have a persistent trigeminal artery, this can be associated with other vascular abnormalities because there was something wrong during the development that caused this artery to remain patent. And then there's a persistent otic artery, and this connects the petrous ICA to the basilar artery. And this is the first of the fetal anastomoses to regress, and therefore the rarest. So that statement should make sense to all of you. And there's only been a few cases that have been reported in the literature regarding this variant. The next variant is the persistent hypoglossal artery, and this connects the cervical ICA to the basilar or the vertebral artery. And this is the second most common after the persistent trigeminal. And this generally arises at the C1 or C2 level. And it goes along cranial nerve 12 through the hypoglossal canal to anastomose with the basilar or the vert. In this type of variant, the ipsilateral PCOM and verts are hypoplastic. And this is important to remember because during your neurosurgery board exam, they'll ask you which fetal, anastomotic variant is most commonly associated or has the highest incidence of aneurysm association, and that's the persistent hypoglossal artery. The last one is the pro-atlantal intersegmental artery, and this connects the cervical ICA at the C2 or C3 level, and it runs posterior superiorly and joins the suboccipital vertebral artery before it goes through the foramen magnum. And there's two different types, obviously. I described the first type. So now you can see, the anterior circulation here, and this is probably the last slide that I'll show. And you can see the ICA running here. You can see the different segments of cervical, the petrous, the lacerum, the cavernous segment here, the communicating segment with PCOM coming off, and then you see the MCA and the ACA. So here in image A, you can see that these vessels go forward. The ACA vessels are supplying the brain. and the MCA has a cutoff. And so, you guys are going to be learning about stroke and new stroke treatments and things like that. And this is called a large vessel occlusion because you have an MCA occlusion here. If you see it, look at image B, this is where the vessel should look like. And, in the last, probably since 2015, since I finished medical school, this treatment of this pathology has, created a whole new realm of interventions for endovascular neurosurgeons, endovascular neurologists, interventional radiologists to treat this pathology. We've come a long way, basically. People used to, you could get TPA for this type of lesion, and then you're written off and you're right off into the sunset. And now we can really impact people's lives by opening up this vessel. And it's probably one of the most rewarding things that we do as endovascular neurosurgeons is removing, an M1 occlusion to resupply the vascular territory of the MCA. So you guys will learn a lot more about this later on in the day. I believe this is my last slide, so I hope this overview provided some usefulness to you guys. So.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.